All right. So, if you take the hemolytic uremic syndrome, first and foremost, you need to be aware of why there is the hemolytic anemia. Okay. So, this hemolytic uremic syndrome is caused by number one, E. coli, and we have another form of the hemolytic uremic syndrome that is called Shigella mediated hemolytic uremic syndrome. Okay. So, we have two things now. One is E. coli, and the other one is Shigella. Now, why there is hemolytic anemia? Right? Why there is hemolytic anemia? Why there is hemolytic anemia is because this Shigella produces a toxin that is called the Shiga toxin. And this particular Shiga toxin activates the complement system. Right? The Shiga toxin activates the complement system. And that will cause the release of the complement. Okay? And it is the complement media. Sorry. It is complement mediated RBC destruction. Right? It's complement mediated RBC destruction. And because of this complement mediated RBC destruction, the individual is having anemia, that is pallor, and the hemoglobin drops down. Okay, hemoglobin drops down. And this complement mediated RBC destruction, this will, we call it as hemolytic anemia, and it is microangiopathic right? It is microangiopathic hemolytic anemia. That is what is the reason you will have the anemia in these patients. Now tell me, is it Coombs positive or is it Coombs negative hemolytic anemia? Yes. Is it Coombs positive? Or is it very good, Vinita? Excellent. Right? And yes, Jacob, right, good. All of you are answering now. So there is no antibody formed in the hemolytic uremic syndrome. Because there is no antibody in hemolytic uremic syndrome, this is considered to be a Coombs negative hemolytic anemia. Right? Coombs negative hemolytic anemia. So that is about the hemolytic anemia. Now, in these patients, there is uremia. Why there is renal failure in these patients? So in patients with the hemolytic uremic syndrome, remember, there is renal failure. Why there is renal failure? Right? Why there is renal failure in these patients? So this is again Shiga toxin. So what this Shiga toxin will do? Shiga toxin will activate the complement system. Okay, so it is Shiga toxin associated or Shiga toxin activated complement mediated vasculitis. Right, it is the complement mediated vasculitis. And because of this complement mediated vasculitis, there is kidney damage, and because of which glomerular filtration rate and urine output, both of them reduces. GFR and urine output, both of them will reduce. And because of decrease in the GFR and urine output, there is increase in urea, and you will have signs and symptoms of uremia. Right, signs and symptoms of uremia. So that is what is the story related to the renal failure. Okay, now what will be the clinical features? Okay, why there is hemolysis, why there is renal failure, we have discussed. But what will be the clinical features? The clinical features is that these patients, okay, I'll write the clinical features separately. So basically, what is the cause? One is Shigella, the other one is E. coli. Shigella, it is associated with the development of dysentery. These clinical features include the initial presentation in hemolytic uremic syndrome will be in the form of dysentery, right? Along with that, they have crampy abdominal pain. Right? They have this crampy abdominal pain. Along with that, because it's an infection, they'll have fever, and as well as how will be the stools? Presence of blood or mucus in stools. Okay, so that will be the clinical features. And when you do a workup in these patients, that is the investigations. Investigations in these patients, they include number one, examination of peripheral smear, right? Examination of the peripheral smear. What the peripheral smear will show the presence of damaged RBC. This damaged RBCs, they are called as helmet cells or Burr cell. Okay, these are also called schistocytes. And what about the Coombs test? Coombs test will be negative because it's not antibody mediated. And kidney function test, the serum creatinine levels, they are elevated. But when you do an ultrasound abdomen, the kidney will be of normal size. The size of the kidney is not affected in these individuals. Then how do you treat these patients? So can we give antibiotics in these patients? Yes. Hmm? No. Very good, Vinita. Antibiotics should not be given. So first and foremost, stop antibiotics. Why, Vinita? Why you should stop antibiotics? Why is that we should not give antibiotics? It's an infective pathology, right? Why we should not give antibiotics? Very good. So when you're killing the organism, the products which are released from the organism that will activate the complement more and more complement get activated. Okay, so that is the reason why you need to stop the antibiotics. Then how will you treat uremia? Hemodialysis that will treat the uremia, and there is hemolysis. So packed RBC transfusion should be given. And is there any role of steroids? No. Okay, steroids are not useful. Okay, and this hemolytic uremic syndrome we classify it to two types based on when the dysentery is present or when the dysentery is absent. So this hemolytic uremic syndrome we classify it as D plus. Dysentery positive hemolytic uremic syndrome. The other one is D negative, that is dysentery negative hemolytic uremic syndrome. Now, in case of D plus, that is dysentery positive hemolytic uremic syndrome or dysentery negative hemolytic uremic syndrome, the manifestations are the same clinical manifestations. But this dysentery negative hemolytic uremic syndrome that develops after chemotherapy. Right? This develops after chemotherapy. CT stands for chemotherapy. Okay. And what is the treatment that you should give? In dysentery negative, you need to give intravenous immunoglobulins. So this is what is called as D negative, that is dysentery negative hemolytic uremic syndrome. Whereas dysentery positive, it is like enterohemorrhagic E. coli or the Shiga toxin, right? Or the Shiga toxin. Okay. And whereas dysentery negative, it is like secondary to your chemotherapy, secondary to your chemotherapy. Okay. That is your dysentery negative. So this is about your hemolytic uremic syndrome. Is this clear for everyone? Now, you have this hemolysis and as well as renal impairment even in case of the TTP, that is thrombotic thrombocytopenic purpura. Even though it's like a chapter of hematology, let me just give you a brief idea. How is it related to your TTP? So your very important difference is you take the hemolytic uremic syndrome secondary to Shiga toxin. It's very commonly seen in children. Whereas TTP in adults, I'll just write that in the form of differences. So one side TTP, thrombotic thrombocytopenic purpura. The other one is Shiga toxin mediated hemolytic uremic syndrome. Okay, so you take TTP. What is the age at which you have this thrombotic thrombocytopenic purpura? That will be adults. Whereas Shiga toxin mediated hemolytic uremic syndrome, the children, right? And usually this Shiga toxin mediated hemolytic uremic syndrome, it follows bloody diarrhea. Right? It follows the bloody diarrhea. And you take the pathogenesis. Pathogenesis, if you see, in thrombocytopenic purpura, it is auto antibody mediated, right? And it is auto antibody to ADAM TS13. Right? ADAM TS13. That is what you see in thrombotic thrombocytopenic purpura. Whereas you take Shiga toxin mediated hemolytic uremic syndrome. This may be what did we discuss? It is secondary to your infection. What is that infection? That is number one, E. coli. That is enterohemorrhagic E. coli. The other one is Shiga toxin. That is the pathogenesis. And what about the platelet count? That is thrombocytopenia. In adults, these patients, they will have very severe form of, right, typically very severe form of thrombocytopenia, right? Except in very early clinical course, these patients, they'll have very severe form of thrombocytopenia. Whereas in case of Shiga toxin mediated hemolytic uremic syndrome, this may be mild or absent. Right? This may be mild or absent. Which one? Thrombocytopenia. And the next important is fever. Fever, it is typical in thrombocytopenic purpura, whereas atypical, that is intermittent type of fever, or occasionally the fever may be absent in case of Shiga toxin mediated hemolytic uremic syndrome. Whereas kidney disease, if you see, in both of them, you have the involvement of the kidneys. And what about the neurological impairment? Neurological impairment, where do you see this? Neurological impairment, it is very classical in thrombotic thrombocytopenic purpura, right? Okay, right? Variable forms of neurological impairment can be there. And in case of Shiga toxin mediated hemolytic uremic syndrome, the neurological impairment, it is seen in less than half of the cases. That will be the neurological impairment in Shiga toxin mediated hemolytic uremic syndrome. And you take the workup. Workup in case of thrombotic thrombocytopenic purpura, you need to check for activity of ADAM TS13. So you will notice that there is decreased right, there is decreased activity of ADAM TS13. Okay, whereas Shiga toxin mediated hemolytic uremic syndrome, they have typically normal levels of ADAM TS13. right? Typically normal ADAM TS13 activity. But what they will have, culture. Culture will be the two stool culture. This will be positive for, right? This will be positive for the Escherichia coli, that is enterohemorrhagic E. coli. Okay. And there is also antibody that can be picked up against the Shiga toxin. That is a workup in both of them. And how do you treat? So hemolytic uremic syndrome, already I have said you the treatment. In case of thrombotic thrombocytopenic purpura, here also you need to do hemodialysis for kidney disease. That is for uremia, you need to do hemodialysis. And you need to give the platelet transfusion. Unless, you see, I'll tell you about the platelet transfusion in detail. Just give me 1 minute. Okay. So one is your hemodialysis, then the other one is plasma exchange therapy. That is your therapeutic plasma exchange. Now, when will you give the platelets? So, platelet transfusion is contraindicated unless TPE is underway. When you have the option of therapeutic plasma exchange, then platelet transfusion is contraindicated. And only like when the TPE, that is your therapeutic plasma exchange, if it is not available, then you need to give the platelets. Okay. Otherwise, the best treatment will be what? That is therapeutic plasma exchange. And why are we doing this therapeutic plasma exchange? Because we are trying to remove that autoantibody. The problem is what? The autoantibody to your ADAM TS13. And we are trying to remove that by your therapeutic plasma exchange. And there's a best way of treatment. And the other way is you can give some monoclonal antibodies in selected patients. And what is that monoclonal antibody is? We have Caplacizumab. This Caplacizumab, it is a monoclonal antibody which is given in selected patients for hemolytic uremic syndrome. Sorry, for thrombotic thrombocytopenic purpura. And for the Shiga toxin mediated hemolytic uremic syndrome, like we do hemodialysis for the severe kidney disease. And is there any role of your TPE, right? That is your therapeutic plasma exchange in Shiga toxin mediated hemolytic uremic syndrome. It is rarely beneficial, right? Rarely beneficial. Only if the adults develop Shiga toxin mediated hemolytic uremic syndrome, then the role of therapeutic plasma exchange is there. Otherwise, in children, no use. And the other thing is supportive care. So these are the differences between your thrombotic thrombocytopenic purpura and then the Shiga toxin mediated hemolytic uremic syndrome. The first important difference is age. Second is the pathogenesis. Age in TTP is adults. Pathogenesis in TTP is autoantibody mediated, autoantibody to ADAM TS13. As the word itself tells you, there is thrombocytopenia, particularly in severe cases, right? Fever you have typically present. Kidney disease is also there, but mild. Okay, neurological impairment variable, lab investigation, decreased activity of ADAM TS13, right? And the mainstay of treatment is therapeutic plasma exchange. Okay, so this finishes your hemolytic uremic syndrome and as well as the thrombotic thrombocytopenic purpura. Now, after having discussed about hemolytic uremic syndrome, now let me just give you a quick recap of the hereditary disorders in the kidney. The hereditary disorders in the kidney, right? You should be answering better than me because you have learned in your pediatrics. So if you take the four important syndromes, that is Barter's, then Gentleman's, then Liddle's, Alport syndrome. Okay. So out of these, your Barter's and as well as the Gentleman's, what is the type of the inheritance? Majority of them, they are like autosomal recessive type of inheritance. Only we have Bartter syndrome type 5, which is autosomal dominant type of inheritance. Liddle's autosomal dominant, then Alport's X-linked recessive. Okay. Now you take the Bartter syndrome first. Bartter syndrome, it resembles loop diuretics. Right? Bartter syndrome, it resembles the loop diuretics. And the subtype of the Barters that we have is Bartter syndrome 1, 2, 3, 4, and Bartter syndrome type 5. So out of this, 1 to 4, autosomal recessive type of inheritance, and type 5, autosomal dominant type of inheritance. Then what is the problem? Pathophysiology in the Bartter syndrome. So first point, there is genetic defect in thick ascending limb of loop of Henle. Right? Genetic defect in thick ascending limb of loop of Henle. What is the channel you have in thick ascending limb of loop of Henle? Sodium potassium 2 chloride. Okay, it resembles the loop diuretics. Okay, so what is the channel which is being defective now? Sodium potassium 2 chloride co-transporter, right? They become defective, and this is the channel which is inhibited by your loop diuretics, right? So once this particular channel is being defective, what is the sequence of events, right? The sodium and water absorption does not occur. Okay, there is no sodium and water absorption, and not only the sodium and the water absorption, sodium potassium 2 chloride, and even the chloride, there is impaired chloride absorption as well. Okay, so right? So there is no sodium and water absorption. So thereby, what will happen to the fluid volume? There will be decrease in the fluid volume, right? There will be decrease in the fluid volume. There is volume contraction, right? So once there is decreased fluid volume, right? Once there is decreased fluid volume, which is nothing but the volume contraction, renal perfusion is also reduced, and that will cause the activation of renin-angiotensin aldosterone system, right? That will cause activation of RAS, and because of this, there is increased production of aldosterone, right? And once there is increased production of the aldosterone, that will promote, right? That will promote sodium uptake and there will be potassium excretion. Because what the aldosterone does, aldosterone will cause sodium reabsorption and then the potassium secretion. The potassium is excreted out, and that will result in hypokalemia, right? That will result in the hypokalemia. Okay. And because of this hypokalemia, what is the effect of hypokalemia on the tubules? Please remember, whenever there is hypokalemia, what will happen is the renal tubular capacity to reabsorb the water is lost. I'll repeat the point again. If there is hypokalemia or whenever there is hypokalemia, the renal tubular capacity to reabsorb the water is lost. And because of this hypokalemia, these patients, they will have polyuria and even nocturia, right? Even nocturia. Now, can anyone tell me what is the relation between the polyuria and prostaglandin E levels? Okay, please tell me what is the physiological action of the prostaglandin E? Anyone of you? The action of the prostaglandin E. Yeah. So the prostaglandin E, right? So that will cause the afferent arteriolar dilatation, right? Afferent arteriolar dilatation. And when there is polyuria and the kidney's capacity to reabsorb the water is lost because of the hypokalemia. So what the body will think that is, there is more and more fluid which is going out because of the hypokalemia. In response to this, there will be abnormal increase in prostaglandin E levels, right? Why there is increased prostaglandin E levels? Anyone of you? Why there is increased prostaglandin? I'm sorry. E levels in these patients. This is one of the very important features. That is, increased prostaglandin E levels is a very, very important feature in these patients with the Bartter syndrome. And we don't want these prostaglandins to be elevated. And that is the reason why the drug of choice in patients with the Bartter syndrome is indomethacin. That is the reason why the drug of choice is the indomethacin. Okay. So urinary prostaglandin E2 levels particularly which levels are elevated is the prostaglandin E2 levels that are being elevated. Okay. And what is the action of the prostaglandin E2? Anyone? Prostaglandin E2. Yes. Action of the prostaglandin E2. Yeah. So this prostaglandin E2 that will decrease the blood pressure of the individual, that will cause vasodilatation, and that will decrease the blood pressure of the individual. Okay. So they will cause low blood pressure, right? And what exactly is the reason why the prostaglandin E2 levels are elevated is not known, but we don't want this prostaglandin to be elevated. And that is the reason why the drug of choice in patients with the Bartter syndrome, it is indomethacin. Right? It is indomethacin. Okay. So you just see the sequence of events what are happening now. There is defect in the sodium potassium 2 chloride channel in the thick ascending limb of loop of Henle. So that is the reason why there is no sodium and water reabsorption. Right? There is decrease in the fluid volume. In response to that, there is activation of RAS. There is aldosterone released, and that will promote sodium and water absorption. That will cause potassium excretion. And in response to your hypokalemia, there is polyuria and as well as the nocturia. And another important point in these patients with the Bartter syndrome is they will have nephrocalcinosis. I'll tell you the reason or the mechanism why they'll have nephrocalcinosis. You see, in patients with the Bartters, there is impairment of the electrical neutrality. Why? Because the sodium and water is getting absorbed, potassium is getting out, H+A1 is going out. So there is defective sodium chloride transport. And this defective sodium chloride transport that will impair the electrochemical gradient. Okay. Why there is nephrocalcinosis is because of defect in sodium, potassium, and 2 chloride channel. There is impairment of electrochemical gradient. And this electrochemical gradient, impairment of electrochemical gradient. And this electrochemical gradient, it is the one which is required to absorb the calcium and magnesium. Okay. So this electrochemical gradient, it is required or necessary for calcium and as well as magnesium reabsorption. Okay. So now once there is impairment of your electrochemical gradient, right, that will lead to increased loss of calcium and magnesium. Right? Increased loss of calcium and magnesium. So there is hypercalciuria. Right? There is hypercalciuria. And this hypercalciuria is what is responsible for development of nephrocalcinosis. Is what is responsible for nephrocalcinosis. Okay. So these are all the abnormalities that you will have in these. And the next point is, what will be the, if you do ABG in these patients, what does the ABG show? ABG will show you that there is metabolic alkalosis. Why there is metabolic alkalosis? Because your H+A1 is excreted out. So there is hypokalemic metabolic alkalosis secondary to secondary hyperaldosteronism. Okay. Now, what are the other features? So what will be the clinical presentation of the patient? The clinical presentation of, so these are all the features until now. Genetic defect in the thick ascending limb of loop of Henle. Right? Because of that, there is activation of RAS. Calcium is out, metabolic alkalosis. The presentation is that the clinical features, these patients, they will have polyuria and polydipsia. Right? Multiple reasons. One is your sodium potassium 2 chloride channel is being defective. And even though there is aldosterone released excess quantity, but because of hypokalemia, again there is polyuria. And what about the blood pressure? Will there be hypertension or normal blood pressure? How will be the blood pressure in these individuals? Very good, Hari. They will have normal blood pressure, right? You may think, sir, that there is activation of RAS, so blood pressure should be elevated. But at the same time, there is polyuria as well. So that is the reason why there is no hypertension. So it is high and okay. And you take this, basically, where is the problem? Sodium potassium 2 chloride channel. And these particular channels, they are also present in the dark cells of the inner ear. Right? These channels, they are also present in the dark cells of inner ear. So once there is defect in the dark cells of the inner ear, the patient will develop sensory neural hearing loss. The patient will develop sensory neural hearing loss. And how will be the face of these individuals? They have triangular faces with drooping mouth. Right, with drooping mouth. And how will be the eyes of these individuals? They have large eyes and pinna. Right? And these patients, they also have renal failure. They also have the renal failure. Okay. And I said you, like, they have nephrocalcinosis, because of which they also have the loin pain because of the stones, right? So this is what is the classical presentation in these patients. And there is hypercalciuria, right? And even the sodium is also lost because sodium potassium 2 chloride channels are defective. So once the sodium is lost, these patients will be craving for a substance which is rich in salt, which is rich in sodium. That is, salt craving will be there. And because of all these, that is polyuria, polydipsia, and the various electrolyte abnormalities, they will have failure to thrive. And they will also have growth retardation. And how will be the appearance of these individuals? I said you that large eyes, triangular face, pinna. I'll just show you that individuals with, yeah. So this is what is the classical appearance. The triangular face, large eyes, and pinna. And because of the hypokalemia, right? So there is hypokalemia, right? So because of hypokalemia, they'll have weakness and cramps in the muscle. And because of hypokalemia, there will be also gastroparesis. Gastrointestinal motility will not be there. So they'll have constipation. They'll have constipation. And what is the drug of choice in these individuals? That is indomethacin. Diagnosis is the same. How will you do the workup of these individuals with the Bartter syndrome? Diagnosis is that, number one, they will have hypokalemia. ABG will show you metabolic alkalosis. Then blood pressure will be normal. But what will happen to urinary potassium? Increased, because there is aldosterone production in excess quantity. Calcium increased because electrochemical gradient is impaired. And urinary sodium that is also elevated because your sodium potassium 2 chloride channels are defective. And what will happen to the serum renin levels? Elevated, right? And what will happen to the aldosterone levels? The aldosterone levels, they also elevated because renin levels are increased. Then followed by that, the prostaglandin E. What did we discuss? Their levels are also elevated. Then what about the magnesium? Magnesium, either it might be hypomagnesemia or normal levels. It is like plus or minus. It is like plus or minus. Okay. And ABG we have discussed. And because of the hypokalemia, when you do an ECG in these patients, you will notice that there is T wave inversion. Okay. And what is the treatment? Drug of choice in these patients is indomethacin. And this is potassium supplements. And they also have hyponatremia, salt supplementation, right? Salt supplementation. So these are the treatment options that we have in patients with the Bartter syndrome, which is like mimicking the loop diuretics. Okay. So if any doubt in this, please ask me, because this is one where you have multiple abnormalities which are going on. Anyways, I'll repeat once. So Bartter syndrome, it resembles the loop diuretics, where the problem is in the thick ascending limb of loop of Henle. And type 1 to type 4, autosomal recessive. Whereas type 5, it is autosomal dominant. And you need to know what is the gene mutated in type 5. That has been asked once. That is CASR gene that is being mutated in type 5. Okay. Whereas the others not required much. You can remember type 1, that is SLC 12A1. This is a gene mutated. Okay. Then, so we have 5 types of Bartters, out of which the first 4 types are autosomal recessive, and the 5th type is the autosomal dominant. And the problem is in the thick ascending limb of loop of Henle, the sodium potassium 2 chloride channels which are present, they are being defective. So sodium potassium 2 chloride is not being absorbed, which mimics your loop diuretics. And because of that, fluid volume is reduced and there is activation of RAS. Reason is not known. The prostaglandin E levels are elevated. Okay. And because of impairment of electrochemical gradient, there is hypercalcemia, right? Hypercalciuria, I'm sorry, hypercalciuria and hypocalcemia. And magnesium may be reduced or may be normal. Okay. And the clinical presentation is polyuria, polydipsia, hypokalemic metabolic alkalosis, sensory neural hearing loss, triangular face, large eyes and pinna, renal failure. And they'll have cramps, weakness, constipation, salt craving. Diagnosis is by potassium levels, hypokalemia, metabolic alkalosis, blood pressure is usually normal, urinary potassium, calcium and sodium are elevated, serum renin, aldosterone, prostaglandin E levels are elevated, and magnesium plus or minus may be reduced or may be normal. And there is increased urinary calcium excretion, and drug of choice is indomethacin. Okay. Then followed by the Bartter syndrome. Yes, please ask me if you have any doubts in the Bartters before we going on to Gentleman's. Next is the Gentleman syndrome. Gentleman syndrome, it resembles thiazide diuretics. It resembles thiazide diuretics. And what type of inheritance is this? Autosomal recessive, right? And what is the problem here? It is the genetic defect in the sodium chloride channels in the where will be the site of action of your thiazides? That is in the DCT. So sodium chloride co-transporter, whichever are there, they become defective in case of your thiazide diuretics. Okay, so these patients, again same story. Once your sodium chloride co-transporter is not working, what will happen? The fluid volume decreases and there is activation of RAS. There is activation of RAS. Okay, that is about the problem in the Gitelman's. And next important is these patients with the Gitelman's, they also have defect in TRP M6. There is another channel. And what is the function of this channel? That is magnesium absorption. Right? Magnesium absorption is the function of your TRP M6. Now, there is a defect in this TRP M6. So, once there is defect in this TRP M6, that will result in hypomagnesemia. That will result in the hypomagnesemia. Now, these patients, right, in the intrauterine life itself, they'll be having polyuria. And once there is polyuria in the intrauterine life, what will happen to the amniotic fluid? Increases, right? So the mother will have polyhydramnios, right? Mother will have the polyhydramnios, right? And there is no sodium and chloride is being lost, right? Magnesium is lost. So there is salt wasting. There is hypomagnesemia. So you'll have features of dehydration, right? You'll have the features of dehydration. And if you just examine the baby, they'll have sunken anterior fontanelle. AF stands for anterior fontanelle. How will be the skin pinch? There will be a delayed skin pinch, right? There will be a delayed skin pinch. And because of dehydration, because of polyuria, because of hyponatremia, even these patients, they'll have failure to thrive. They'll have failure to thrive. And the next important in the Gitelman syndrome is that they also have hypokalemia. So why is that they are having hypokalemia? Because there is activation of RAS here, right? Once there is activation of RAS, the potassium is excreted out. So that will result in the hypokalemia. Once there is hypokalemia, right, they have cramps, right? They have spasms, right? Cramps and spasms within the muscle, okay? Muscle cramps and as well as the spasms, right? And then because of your hypokalemia, you take in the baby, there will be a sluggish or a poor cry, right? Sluggish or poor cry. And when you do an ABG, like what it will show you, same thing, right? Because your RAS is activated, H+1 is excreted out. So ABG will show you that there is presence of metabolic alkalosis. And how will be the blood pressure in these individuals? The blood pressure, very good, Hari. The blood pressure will be absolutely normal. Even though there is activation of RAS, right? the defect is like resembling thiazide diuretics. So the fluid is out. So there is blood pressure being normal. Now, can anyone tell me, because of hypomagnesemia, will there be any endocrine abnormality? Hmm? Will there be any endocrine abnormality because of hypomagnesemia? Yes. Insulin resistance? Huh? No. Hmm? So whenever there is hypomagnesemia, please remember there is absence of parathormone release. Right? There is absence of parathormone release. Okay. And once there is absence of parathormone release, what will happen to calcium levels? Reduced. And that will result in tetany. Right? So these are the features that you will have in the patients with the Gitelman syndrome. Right? And what are the other features? The presentation is usually in the early childhood or late childhood. Okay. So early or basically in the childhood that you should remember. Okay. And the clinical presentation will be in the form of polyuria. Why they will have polyuria? Because of hypokalemia. Whenever there is hypokalemia, right, the absorption capacity of the right polyuria and nocturia. So because of this polyuria and as well as nocturia, these patients, the absorption capacity in the tubules is lost. All right, and labs already we have discussed. It is metabolic alkalosis, hypokalemia, hypomagnesemia will be there, right? And the blood pressure will be normal. That is about your Gitelman syndrome. And in case of Gitelman syndrome, one more important point. Actually, what is the investigation of choice? Investigation of choice is 24-hour urinary chloride. What will happen to the 24-hour urinary chloride levels? Anyone? 24-hour urinary chloride levels? Yes, increased. Good. Why? It's not a big thing to think, right? In the sense, like it is very simple concept. Okay, sodium chloride's co-transporter is inhibited or defective, so chloride is out. So thereby, investigation of choices, 24-hour urinary chloride levels. Why are we not taking 24-hour sodium levels? Why? Because of the activation of RAS, aldosterone is released that can cause sodium absorption, and that is the reason why we are not taking the sodium into the consideration here. So this is about the Gitelman syndrome. So I'll just do a quick recap of like what's going on in the Gitelman syndrome. So Gitelman syndrome, it's a disorder of sodium chloride symporter at the level of the distal convoluted tubule. And type of inheritance is autosomal recessive, commonly seen in children. And because of defect in sodium chloride co-transporter, the fluid volume is reduced. So thereby, there is activation of RAS. And these patients, they will not have hypertension. Presentation will be mainly in the form of polyuria and nocturia. There is also hypokalemia in these patients, because of which there will be muscle cramps and spasms. There will be also polyuria. And there is hypomagnesemia in these patients because of defect in TRPM6 channel. And because of hypomagnesemia, there is hypoparathyroidism causing hypocalcemia and tetany. And labs, you have 24-hour urinary chloride levels are elevated, and that is the investigation of choice. And plasma or serum will show you hypokalemia, hypomagnesemia. And in these individuals, like they'll have signs of dehydration, like mainly in the children or infants, they'll have sunken anterior fontanelle and delayed skin pinch. And intrauterine life, the mother will present with polyhydramnios because of your polyuria. And the treatment is like completely symptomatic treatment. Hypokalemia is there, supplement potassium. Hypomagnesemia is there, supplement magnesium. Hypocalcemia is there, supplement calcium. So it is like completely symptomatic treatment that you need to give. There is no particular drug which will completely reverse this Gentleman syndrome. Okay, so this is about, and this is also autosomal recessive. Now, so what are we done with? We're done with Barter's, Gentleman's. Now, let us take up the discussion of Liddle's. Liddle's very simple, not a difficult one to understand at all. Liddle syndrome the type of inheritance is autosomal dominant type of inheritance. And what exactly is the problem? It is gain of function of ENaC channel. Right, gain of function of the epithelial sodium channel. And because of the gain of function of the ENaC channel, what will be the features? There will be sodium and water retention, potassium excretion, and H+ion excretion. Because of sodium and water retention, these patients, they will have hypertension. Where are your ENaC channels present? And ENaC channels are the channels for which hormone? Yes. Where are your ENaC channels present? And yes, so ENaC channel is the channel for aldosterone. And where are these ENaC? Not collecting duct, Vinita. Distal convoluted tubule in the DCT. DCT, mainly in the DCT. Right? Now, what is the drug of choice in these patients now? What drug we will give? Very good, Jacob. So that is, you need to give the ENaC blocker. That is epithelial sodium channel blocker. Example for that, because the problem is gain of function of ENaC. You block that ENaC. That is amiloride. And one more example of ENaC blockers, apart from amiloride. Yes, one more example. Very good, Hari. That is triamterene. Right, triamterene. Right. So this is about your Liddle's. And Liddle's is a differential, close differential diagnosis for what? For which endocrine disorder? It's a differential diagnosis for, very good, Jacob, that is Conn syndrome. And what is the drug of choice for Conn's? Drug of choice for Conn's is spironolactone. And what is Conn syndrome? Conn syndrome is hyperaldosteronism. And where will this aldosterone act? Aldosterone also will act on epithelial sodium channels only. And in Liddle syndrome also, there is gain of function of epithelial sodium channels. So both of them, the end effect will be same, but the treatment is different. In Liddle's, you block that ENaC, and in Conn's, you block that aldosterone release, or aldosterone you block. That is your spironolactone, which is an aldosterone antagonist. What is the alternative to your spironolactone? Alternative to spironolactone, right? Very good. So that is eplerenone. What is the important adverse effect that you come across with spironolactone? Important adverse effects with spironolactone. Gynecomastia, and that too, a tender gynecomastia. That too, a tender gynecomastia. Okay. And what are all the drugs which will cause gynecomastia? What are all the drugs which will cause gynecomastia, right? Digoxin, isoniazid, then spironolactone, then ketoconazole, then estrogen supplements. It is not ranitidine, it is cimetidine, right? It is the cimetidine. Okay, right. Now that was about your Liddles. Now the last one what we have is the Alport syndrome. See, Alport syndrome and Goodpastured syndrome, you should not you should not have any confusion. In Alports, it is alpha 5 chain of type 4 collagen. That is in Alports. Whereas you take in case of the Goodpastured syndrome, it is alpha 3 chain of type 4 collagen. Okay, so in Goodpastured, it is alpha 3 chain of type 4 collagen, whereas in Alports, alpha 5 chain of type 4 collagen. Right? Now, let me discuss in detail about the Alports. The defective is where? The defect is in type 4 collagen. But in this type 4 collagen, you have totally 6 chains. That is alpha 1, alpha 2, alpha 3, alpha 4, alpha 5, alpha 6. There are totally 6 alpha chains. And out of which alpha 1, alpha 2, the gene required for synthesis of alpha 1, alpha 2 chain, it is present on chromosome 13. Whereas gene required for synthesis of alpha 3 and alpha 4 is present on chromosome number 2. And gene required for synthesis of alpha 5 and alpha 6 present on chromosome number 6. Okay, that is about your type 4 collagen. Now, out of which you take the last 3, that is alpha 3, alpha 4 and alpha 5, sorry, middle 3. This alpha 3, alpha 4 and alpha 5, where are they being distributed? Right, they are distributed on the glomerular basement membrane, right, distributed on in the cochlea, distributed in the lens capsule, right, distributed in the lens capsule, right. So these are the 3 places where your alpha 3, alpha 4 and alpha 5 chain are distributed. And in Alports, what is the problem? It is in the alpha 5 chain. So that is the reason why you will have all these 3 manifestations in the Alports. You will have glomerular, the kidney problems, cochlea, ear problems, lens, that is the ophthalmic problems. So all these are being defective. Right? All these are being defective. So accordingly, you will have a triad in patients with the Goodpastured syndrome. What is a triad? The kidney involvement in patients with the Alports will be hematuria. And this hematuria is the earliest manifestation. So can anyone tell me which form of glomerular pathology these patients will develop? I have discussed today itself. Can anyone tell me which form of glomerular pathology these Alport syndrome develop? What is KGA, Vinita? IgA nephropathy, right? So these patients, they develop, you just see the focal segmental glomerulosclerosis. You just see the focal segmental glomerulosclerosis. Yeah. So these patients, they develop FSGS form. And Vinita, IgA nephropathy, it is secondary to your gastrointestinal, secondary to your upper respiratory, secondary to your urinary tract infections, right? That is what is your IgA nephropathy. But you just go back to your notes on the focal segmental glomerulosclerosis, right? In secondary FSGS, you see, we have discussed the Alports. In secondary FSGS, you have this Alports, okay? Right. Now, because of defect in the kidney, these patients, they'll have hematuria, and it's nephrotic syndrome. So they'll have proteinuria, then they'll go into a state of progressive renal insufficiency. Right? And there's defect in the cochlea. So this will be resulting in sensory neural hearing loss. And sensory neural hearing loss, this will be the most common extrarenal abnormality. Right? Most common extrarenal abnormality. And the sensory neural hearing loss that you will have is asymmetric. Right? It is asymmetric sensory neural hearing loss. Right? So that will be, and this is the most common extrarenal abnormality. Then followed by that, the lens capsule, that is ocular abnormality. There will be anterior lenticonus, where there will be bulging of the lens. And these patients, they also have development of cataract. Then retinal detachment, nystagmus, and they also develop corneal ulcerations. Okay, so these will be the problems in the Alport syndrome. And treatment is like completely symptomatic treatment, right? Whatever the symptom, accordingly you need to treat the patient, right? So that completes the discussion of the hereditary disorders of the kidney. That is your Gitelman's, then your Barter's, Liddle's, Alport's, right? So we are done with the nephro part. So you just take a break for 10 or 15 minutes. So it's like 5:45 now. We will reassemble back again at 6, and then we will discuss the multiple choice questions of all the topics like whatever we have discussed until now. Okay, just take a break for 10 or 15 minutes. So now we'll try to solve some of the multiple choice questions. A general practitioner has referred 20-year-old patient to the renal clinic with hematuria. The patient recalls having coryzal symptoms 2 weeks ago and then developing frank hematuria for few days. He says the symptoms are resolved. The patient recalls his maternal grandfather had kidney problems at the young age. He has past history of hearing difficulties and wearing hearing aids and is under the ophthalmologist for the treatment of corneal ulcer. Evidence of what underlying diagnosis is likely to be seen on renal biopsy. Right. Jacob, why did you answer C? Yes, Jacob, why did you answer C? Primary focal segmental glomerulosclerosis. Achha, now you changed. Okay, fine. Right. So the answer is no, not only FSGS, not only kidney problem. The individual is also having the hearing aids, corneal ulcer. So this is a classical triad that you see in patients with the Alport syndrome, right? 66-year-old women with poorly controlled type 2 diabetes presents to accident emergency. 2 days history of severe pain in the right flank, nausea, fever that come and go. On examination, the patient appears unwell, sweaty, temperature 38, denies any recent travels, urine dipstick is positive for protein, blood, leukocytes, and nitrates. CT abdomen reveals gas in the perineal parenchyma. What is the most likely diagnosis? Very good. Why Kamalanathan? Why did you go for tuberculosis, Kamalanathan? What made you think of tuberculosis? Okay, now you have changed. Okay, right. So it is classical case of pyelonephritis. So it's like, what could be the cause for the pyelonephritis in this patient? What is the risk factor? What is the risk factor for? Very good, Vinita. So it's like poorly controlled diabetes mellitus. That is a risk factor for the development of your pyelonephritis in this patient. Okay, then. Yeah, did we discuss this? I don't think. Okay, a 49-year-old woman attends to a clinic suffering from chronic renal failure due to progressive glomerular disease. She appears well, blood pressure 145, 1 by 92 millimeters of mercury. Blood tests reveal elevated phosphate, serum creatinine, and urea. Calcium levels are low. Estimated GFR 35. You also notice that the patient cholesterol levels are moderately raised. The most appropriate management in this patient. Directly jumping onto dialysis, Hari, Vinita, Soumya, why you want to do renal dialysis? Okay, Vivekanandan, D, Cinacalcet. Jacob and Kamalnathan, oral vitamin D. Okay. Any other answer? So first of all, which stage of chronic renal failure is this? That is stage or grade 3. Grade 3 of chronic renal failure. Yeah. Grade 3B. And accordingly, the patient is having hypocalcemia, then hyperphosphatemia, and then the serum creatinine and urea is also elevated. Now, the options are sevelamer hydrochloride, parathyroidectomy, oral vitamin D, Cinacalcet, renal dialysis. When will you do renal dialysis in chronic renal failure? That is stage 5. So, in stage 5, we do this renal dialysis. Okay? Next, giving Cinacalcet. What is the purpose of giving Cinacalcet? That is mainly to reduce that parathormone production because it's a calcium mimetic agent. Next, now you're giving, many of you have answered C. Okay, what is the purpose of oral vitamin D? Why do you want to give vitamin D? Yes. Why do you want to give vitamin D for this patient? Yeah, you want to increase the calcium. Great. It's a good thing that you have thought that. But the point you tell me, these patients are having elevated phosphate. When there is an elevated phosphate, when you increase the calcium, what can happen? When there is an elevated phosphate, and you are trying to increase the calcium, that results in calcium phosphate. So your primary thing is decreasing the phosphate or increasing the calcium. What is your primary treatment? Decrease the phosphate, then followed by that increase the calcium, then followed by that increase the calcium. The answer is not C. Many of you have answered C. The answer is sevelamer hydrochloride. Okay, so that is, we have discussed. It is not that the point I didn't discuss. I have already taught you that these patients are having hypocalcemia because of 2 reasons. One, because of your vitamin D deficiency. Second thing is because of your calcium phosphate stone formation, right? So your primary target should be to decrease the phosphate and then increase the calcium. And if you miss that point, your answer is gone. So none of you have answered this. Yes. Yeah, answer this. 21-year-old man presents with lethargy over the last week, periorbital edema and proteinuria. Patient mentions he has been to hospital a number of times in the past due to the same symptoms as well as mild eczema. Okay. Light microscopy, renal biopsy normal. Electron microscopy, diffuse effacement of epithelial podocytes. Most appropriate treatment. Yes. What is the most appropriate treatment? Yes. What is the diagnosis? What is the diagnosis? That is minimal change disease. Okay. So you should give oral prednisolone, right? Next. Yeah. Patient with nephrotic syndrome on long-standing corticosteroid therapy may develop all of the following except. Very good, Jacob. So they will not have the hypertrophy of the muscle. So individual with long-standing steroid, they develop Cushing's. What they develop is they will develop proximal myopathy. They will develop proximal myopathy. So they will have loss of muscle mass, but hypertrophy of the muscle will not be there. And hyperglycemia will be there, neuropsychiatric symptoms will be there, and suppression of hypothalamo-pituitary adrenal axis also will be there. Okay. Yeah. Membranous glomerulonephritis is associated with multiple answers are there. Multiple answers are there. They're associated with renal vein thrombosis, right? Associated with subepithelial immune deposits. Okay. And very rarely they can have hematuria, right? So the answer is A, C, and D. Okay. Next. Whereas you take this Hodgkin's disease. Hodgkin's disease is associated with which form of nephrotic syndrome? Hodgkin's is associated with which form of nephrotic syndrome? Anyone? Very good, Jacob. That is minimal change disease. Minimal change disease. Yeah. Except minimal change glomerulopathy may be seen in association with all of the following except. Right. That is Hep B, HIV, drug-induced interstitial nephritis, and as well as the Hodgkin's. Now, if you take the etiologies of MCD, we have discussed drugs, we have discussed toxins, we have discussed infections, we have discussed the tumors. We have discussed the tumors. Yes. If you see the table which I made you to write, this is a table that you have written. I think you have missed writing HIV. Please add HIV to your options. The one which will not cause, drugs will cause. Drug-induced interstitial hepatitis, it's a part of drug-induced interstitial nephritis, it's a part of your minimal change disease. I have given you a big list of drugs, right? Then Hodgkin's, just now we were discussing. Then even your HIV is associated, but the one which will not cause is hepatitis B. Hepatitis B will not cause your minimal change disease, right? The answer is A. And hepatitis B is associated with which form of nephrotic syndrome? Hepatitis B is associated with which form of nephrotic syndrome? Right? Yeah. So that is associated with focal segmental glomerulosclerosis associated with FSGS. Okay. Yes, clinical feature of minimal change glomerulonephritis are all except. Right, that is, hypertension will not be there. These patients, what did we discuss in minimal change disease? They'll have normal blood pressure, right? Edema, selective proteinuria, fever will be there. And fever will be there when, if it is an infectious pathology causing minimal change glomerulonephritis. But hypertension will not be there. They will have normal blood pressure. 7-year-old boy presented with generalized edema, urine examination revealed marked albuminuria. Serum biochemical examination showed hypoalbuminemia with hyperlipidemia. Kidney biopsy was undertaken. On light microscopic examination, the kidney appeared normal. The electron microscopy examination is most likely to reveal it. Right. So that is the fusion of the food process of the glomerular epithelial cells. That is A. And why there is fusion of the glomerular epithelial cells? Yes, why there is fusion of glomerular epithelial cells? Yeah, so that is loss of proteoglycan, that is heparan sulfate proteoglycan, right? So the answer is A. And can anyone tell me what exactly, this is a patient with minimal change disease. What do you think the problem of this patient is? Jacob, what is the problem? Yes, very good. So this patient is on long-term steroids, develop Cushingoid appearance, developed Cushingoid appearance. Okay. Yeah. Answer this. Multiple options are there. Hypocomplementemia is seen in. I have given you a table. The conditions where the complement levels will be normal and the conditions where you will have hypocomplementemia. I have given you a flowchart also. Yes. PSGN, membranous glomerulonephritis, focal segmental glomerulonephritis, MPGN, infective endocarditis. Okay, so everyone is very clear with the PSGN. There's no doubt in the PSGN because we have discussed PSGN in detail. And I said you that in first 1 to 2 weeks, there will be hypocomplementemia. And by 4th week or 6th week, the complement level will return back to normal. So everyone are very clear that the hypocomplementemia will be there in post-infectious glomerulonephritis. But in the list, if you observe, I have also said you about the infective endocarditis. And even please add membranoproliferative glomerulonephritis as well. So it is seen in PSGN, membranoproliferative glomerulonephritis, and as well as the infective endocarditis. These are all the conditions where you will have the hypocomplementemia, right? Answer. Very good, Vinita. So no change is seen. In light microscopy, in minimal change disease, we have discussed that there is no abnormality at all. Child had hematuria and nephrotic syndrome was diagnosed. What is the true statement about this? Right, very good, Kamalanathan. So it is the glomerular function is lost due to loss of polycharge on both sides of the glomerular food process. The answer is D. Yeah, these questions we have discussed, and that was some of the questions on minimal change and yeah, membranous glomerulonephritis, rarely they can have hematuria. Rarely they can have hematuria. Okay. Right. Adult polycystic kidney disease inherited as autosomal dominant. Chromosomes involved in ADPKD, that is 4 and 16. But on chromosome 4, you have gene for On chromosome 4, you have the gene for PKD2, PKD2. Whereas on chromosome 16, you have PKD1. All are true except. Right. So which is the incorrect statement here? That is first option A. That is hypertension is rare in adult polycystic kidney disease is wrong statement. We have discussed that it is present in almost 75% of patients. Okay. The answer is A. Associated with adult polycystic kidney disease. That is Berry aneurysms of circle of Willis. Berry aneurysms in circle of Willis. The answer is A. Okay. So this is your Berry aneurysms. This is the most common site. That is junction of anterior cerebral and anterior communicating artery. And this is your diverticulosis, which gives you a sawtooth appearance on barium enema. And then you'll have mitral valve collapse. Seen in all organs except that is in the lungs. In the lungs, you don't have this is except. And what is the most common extrarenal site? What is the most common extrarenal site? The most common extrarenal site will be liver. Most common extrarenal site will be liver. Okay, that was about your adult polycystic kidney disease, right? Just 1 minute. I'll take a few more questions. Right. So some of the questions on Goodpastures. Please answer this. Characterized by. Okay. Actually, the question should be characterized by all except. Now you answer. Characterized by all except. That should be the question actually. Yeah. So you will not have. Some of you are answering B. I said you Goodpasture syndrome, it's a form of your RP gene. It comes under RP gene. You have the presence of crescents, right? And diffuse alveolar damage will not be there. There will be focal alveolar necrosis. Please see your notes. In the lung part, I have mentioned it as focal alveolar necrosis. You will not have diffuse alveolar damage in this patient. Okay, so the answer is D. And this is the chest X-ray in these patients. What will be the chest X-ray finding we have discussed? Bilateral infiltrates. Bilateral infiltrates. Right. So that was about one important question in the Goodpastures. Let me take up some clinical based questions. Yes. So a 44-year-old female received a cadaveric renal transplant 8 weeks previously. At a routine transplant clinic appointment, she is well and on following medication: cyclosporin, azathioprine, prednisolone, cotrimoxazole, and lisinopril. ECG shows peaked T waves and prolonged PR interval. Which is the most appropriate initial therapy in this patient? Right. Soumya, why did you go for option B? What is the most appropriate initial therapy? That will be intravenous calcium gluconate. That is the drug of choice in patients with the hyperkalemia. And followed by that, your insulin plus dextrose is very much required. Insulin plus dextrose, that is required for reducing the potassium levels. That is required for reducing the potassium levels. That is the quick and earliest. Whereas calcium gluconate, they don't reduce the potassium, but they will what is that? They will sensitize the myocardial membrane to prevent the development of arrhythmias, right? That is the first thing, right? And the patient is on lisinopril, yes, but that will be the next step. That will be the next step. Okay, stop or withdraw the lisinopril. But the first thing, as the patient is there with you now, with a potassium of 6.9, what is the thing that you should do first is IV calcium gluconate. Is that clear, Jacob? And subsequently, you should advise the patient not to take lisinopril, because that will also cause hyperkalemia. Okay. 72-year-old woman has reviewed in outpatients having recently been treated with furosemide and amiloride combination tablet for heart failure. You understand that GP inappropriately increased the number of combinations tablets 6 weeks ago, rather than just increasing the furosemide component. She also has history of angina, for which she takes slow release nitrates preparation. On examination, blood pressure is 130/80. Chest examination unremarkable, and heart sounds were normal. ECG showed deep Q waves in the anterior leads, but was otherwise unremarkable. Her amiloride has been stopped that day. What further urgent actions needed to be taken with respect to the potassium? Yes, Jacob, you want to give calcium gluconate. Okay, fine. Right. So Vinita is very clever, right? So that is why nothing, Vinita? You have opted for none. Why? Right, because there's hypokalemia in this patient. Why there is hypokalemia? Why there is any point suggestive of hypokalemia? There's nothing to tell hypokalemia. Amiloride. Okay. Amiloride will cause what? It's an ENaC blocker. It will cause hyperkalemia. Amiloride will cause hyperkalemia. Okay. But at the same time, the patient is also being given furosemide. So one is increasing the potassium, amiloride. The other one is decreasing the potassium, that is furosemide. So the potassium level is maintained, right? The answer is none, C. Jacob, why did you go for A? Why were you thinking of A? What point is suggestive of hyperkalemia in this patient? Is there any point in the question suggestive of hyperkalemia? They stopped the amiloride. If they stopped amiloride, it is the patient is on furosemide. Furosemide will reduce the potassium. So what is the purpose of giving your calcium gluconate when there is no hyperkalemia? And the other point is ECG shows only deep Q waves. There is neither changes of hyperkalemia, there is neither changes of hypokalemia. Right? Okay. So if at least hyperkalemia was there, ECG would have shown that tall T waves, but they are not there. That means the potassium levels are maintained or balanced. Okay, that was like by mistake. The question says, you understand that GP inappropriately increased the number of combination, right? Amiloride was not required, but GP has increased. So what you have done as a cardiologist, you have stopped that amiloride, which will be of no use. But why GP added? GP thought that furosemide will decrease the potassium. Let me add amiloride. That will increase the potassium. That was the GP thought process. But amiloride is not given in heart failure. We give aldosterone antagonist, spironolactone in heart failure. Okay. So the answer is C. Right, a little tricky. Yeah, you see the next question. 56-year-old man with chronic renal failure is admitted, arthroscopy, right knee. Admission reveals potassium 5.9, creatinine 450 micromoles per liter, urea 28. Which of the following steps present the best plan with respect to his surgery? Right, good. So there is potassium levels of 5.9. Hyperkalemia is there. So definitely you need to treat that hyperkalemia. Okay. So surgery should be delayed until the potassium is below 5.5. So if you first correct hyperkalemia, because this is a very common referral coming from surgical departments to the medicine department. Potassium is on the higher side. Please come and see what to do next. Okay. So these patients, what we will give? We will give the calcium gluconate and then insulin plus dextrose, reduce the potassium to 5.5, then the patient should be taken for surgery. Right? Until then, no. You're asked to urgently review a 62-year-old man who is admitted to the emergency department. There's a past history of chronic renal failure. On this occasion, he complains of increasing shortness of breath. On examination, he has a blood pressure of 90/60, heart rate 100 beats per minute. He has a pericardial rub, bilateral crackles consistent of heart failure. Both legs are swollen to the thighs. Which of the following represents the best treatment option in this patient? See, when the patient is jumping on the bed with increasing shortness of breath, now Vinita and Soumya, please tell me, when the patient is having increasing shortness of breath, what could be the reason for the shortness of breath in this patient? Pulmonary edema. A patient with pulmonary edema, can he undergo hemodialysis in supine position? A patient with pulmonary edema, can he lie down in supine position? And can he undergo hemodialysis? He cannot lie down in supine position, first of all. Okay. Why? Because of pulmonary edema. So first clear the pulmonary edema. Right? And for clearing the pulmonary edema, what is that you need to do? You need to give intravenous furosemide. After clearing the pulmonary edema, then you go ahead with your dialysis because the patient had developed pulmonary edema. Actually, pulmonary edema is an indication for dialysis, right? But because the patient is not in a position to undergo hemodialysis because of pulmonary edema, so give IV furosemide, then you need to plan for dialysis. And the other point is, you want to take the patient to the dialysis, Soumya and Vinita. What is the most common complication of hemodialysis we have discussed? What is the most common complication of the hemodialysis? Yes? That is hypotension. Okay. So you see the patient's blood pressure 90/60. Right? Patient's blood pressure is 90/60. Okay. So with that blood pressure of 90/60, if you take to the dialysis also, the individual may develop significant hypotension. So first try to correct with limited dose, try to correct that pulmonary edema with limited doses of your furosemide. Then you can plan for the hemodialysis. Then you can plan for the hemodialysis. Okay. Right. Otherwise, if we don't check the blood pressure, if you don't see the blood pressure, we immediately jump onto what? We immediately jump onto, yeah, that's what. First of all, dialysis to nahi kar sakte. Jacob, dialysis to definitely we cannot do. Right? Yeah, that's what I'm telling you. Limited doses of furosemide should be given. Monitor the blood pressure and then give furosemide to reduce that pulmonary edema. Along with furosemide, you need to add the inotropic agent, which is not given here. Actually, you need to add the inotropic agent to increase the blood pressure. Okay. So first, the individual has to be stabilized first from the pulmonary edema. Then you can plan for the hemodialysis. Jacob, did you get that? So you need to add inotrope there. Yes, like noradrenaline and all we need to add. Yeah. 40-year-old women with end-stage renal failure undergoing regular hemodialysis is due to that means he is like due for undergoing renal transplantation from her sister the following day. The primary cause of her renal failure is hypertension, right? And she has no past medical history. Examination blood pressure is 145/70. Chest and abdominal examination is unremarkable. Which of the following represents the best treatment plan? And the values of your investigations are given there. The sodium 134, potassium 5.8, urea 15, creatinine 370, hemoglobin 8.9, WBC 5,000, platelet 2.43 lakhs. So give calcium resonium, consider dextrose and insulin infusion. Don't do anything. Arrange an extra hemodialysis session. Give regular salbutamol nebulizers. What is that you want to do? Yes, Jacob, you want to give regular salbutamol nebulizers. Okay, fine. And Soumya also regular salbutamol nebulizers. All right. Any other answer? Very good, Vivekanandan. Yes, Vinita and Vivekanandan. We have got the correct answer. What is that? Arrange an extra hemodialysis session. You take this, the patient is having end-stage renal disease and there is hyperkalemia of 5.8 millimoles per liter. Definitely potassium levels are high, right? And we don't know the previous potassium levels also. End-stage renal disease with hyperkalemia, what do we suspect? Do we suspect acute hyperkalemia or do we suspect chronic hyperkalemia? Chronic. We suspect chronic hyperkalemia, right? Okay. Now, you take this calcium resonium, dextrose and insulin, salbutamol nebulization. All these are the treatment for acute hyperkalemia or chronic hyperkalemia? For acute. For acute hyperkalemias, we give this calcium gluconate, insulin plus dextrose, and then salbutamol nebulization. So that is the reason why your A, B, and E, they are not the correct statements. The correct statement is D. Arrange an extra hemodialysis session in this patient. The answer is fourth option. Now, if we don't apply this knowledge or the concept that calcium carbonate, dextrose, and your insulin and salbutamol nebulizers are given for acute, we don't know. If we don't apply that concept, there's a very high chance that we may do a mistake in this question. Okay. So, and the other point is K plus increased in a case of end-stage renal disease, we need to think of chronic hyperkalemia. So the answer is arrange an extra hemodialysis session in this patient. Okay, so the answer is D in this patient. It is not your insulin plus dextrose or salbutamol nebulizers, right? Yeah, the answer is D. Arrange an extra hemodialysis session in this patient. Yes. 48-year-old man, painless microscopic hematuria discovered by GP at OPD. Vague right iliac fossa pain. There's no past medical history of tuberculosis in chest X-ray is suggestive of right apical fibrosis. Father died of brain hemorrhage. Examination blood pressure 160/100. Palpable mass on ballotting the right kidney. Very good. So all of you have answered it correctly. That is ADPKD, autosomal dominant polycystic kidney disease. What could be the reason for his father died of brain hemorrhage? Berry aneurysms. Good. Subarachnoid hemorrhage. That is subarachnoid hemorrhage. Okay. Next. Where do you get this kidney? I have shown you almost similar picture. Very good, Jacob. That is medullary sponge kidney. What did we tell you? That is flower bouquet appearance or paintbrush appearance, right? On the intravenous pylography. Right. A 24-year-old man presents with microscopic hematuria. He is seen a few days following upper respiratory tract infection. Urine positive for blood and protein. No growth seen after the urine culture. Blood pressure normal. Renal biopsy reveals focal proliferative glomerulonephritis with mesangial IgA deposition. Okay, so this is a straight question. There's not a big deal in this. It is. Question itself is telling you that there is presence of IgA. That gives a clue for us. Right. Next question is very important. 68-year-old man with long history of chronic renal failure admitted for angiography. He is kept in over the weekend and you are asked to review him 3 days post-procedure. Nursing staff have noticed a purpuric rash over the feet and think the blood supply to the lower limb is impaired. Blood test revealed ESR 86, eosinophilia, creatinine 450. Which of the following stems represent the most likely diagnosis? Very good. Excellent. Right. I have given you more or less the similar picture yesterday when we were discussing atheroembolic disease. Atheroembolic disease. I have taught you the same. Patient had undergone coronary angiogram. And what is that? In the feet and as well as in the feet, what is that? You'll have rash, purpuric rash will be there. And that is because of the cholesterol emboli or atheroembolism entering into the digital circulation also. Okay. So the answer is D, fourth option, cholesterol. What are the points in favor of cholesterol embolism? What are the points in favor of cholesterol embolism? Purpuric rash and as well as the eosinophilia. Purpuric rash and as well as the eosinophilia. Okay, right. So that was the question on pulmonary embolism. Sorry, cholesterol embolism. 74-year-old woman is admitted by ambulance having been found by her daughter on her floor, hall floor. It appears that she has been there for some hours. She has a past history of hypertension, which is treated with ramipril 10 milligrams daily, and the TIA for which she is taking treated aspirin. She is also having history of TIA for which she is taking aspirin. On examination in the emergency room, her blood pressure 120/70, pulse 105, pyrexia, evidence of right-sided pneumonia. It's a fracture of left femoral neck. In addition, investigation have been revealed which of the following apart from pneumonia would best explain some of the other results seen here. Acute myocardial infarction, urinary tract infection, rhabdomyolysis, fat embolism, subendocardial myocardial infarction. Go through your investigations workup also. And what about others? Yes, Jacob, what is your answer? Right. So the correct guess or the correct answer is given by Vinita, right? Very good, Vinita. You are the only one who has answered this. Yes, Vinita, tell me, why did you think of rhabdomyolysis? What made you to think of rhabdomyolysis? Very good, Vinita. Excellent. That is creatinine kinase. You just check the value of CK. The normal value is 24 to 170. It is given in your bracket there. And CK value is 3890. Whenever you have the creatinine kinase levels elevated, the creatinine kinase levels will be elevated in case of rhabdomyolysis. Right. Vinita, why don't you think of anterior myocardial infarction? That's what I'm asking. Why don't you think of the anterior myocardial infarction? Very good. There is no corresponding ECG. I have given you the ECG also there, right? Lateral ST segment depression is there. In case of anterior myocardial infarction, V1 to V4 ST segment elevation should be there. V1 to V4 ST segment elevation should be there. ST segment depression in the lateral is not suggestive of your anterior myocardial infarction. So your A is incorrect. What is the correct answer there? Is your CK. That is your C, rhabdomyolysis. All right. Okay. Next. And yes, many of you were answering fat embolism. Why you people have answered fat embolism? Why you people have answered fat embolism? Many of you, like yes, many of you have thought fracture of the femoral neck. But Hari, on urine examination in fat embolism syndrome, what is that you will observe? I have taught you this. In the urine analysis, I have taught you. In fat embolism syndrome, you will have the oval fat bodies. You will have oval fat bodies. Do you have that on urine examination? What is given? It's positive to blood on dipstick, but no cells seen on microscopy. So it is not at all your fat embolism, right? So we cannot think. And the creatinine kinase levels are not elevated in fat embolism syndrome. Okay, right. So the answer is C. That is rhabdomyolysis. Yeah. So the next question is 39-year-old man presents to the renal clinic with hypertension worsening renal function. GP has tried to manage his blood pressure for many years and currently treated with ramipril and amlodipine. He does not know his family medical history as he is adopted. Examination, blood pressure is 155 by 92. You can feel bilateral flank masses. You also feel irregularly enlarged liver. Investigations have been given. Which of the following is the most appropriate problem associated with the underlying diagnosis? Jacob, what are you talking about? But it is always present. Are you asking about the oval fat bodies? Yeah. Fat embolism syndrome, almost 90% they'll have the oval fat bodies. 80 to 90% they'll have. But the other point is, in fat embolism syndrome, the creatinine kinase levels are not elevated. That's completely against your fat embolism syndrome. But otherwise, the oval fat bodies, they are present in at least 80 to 90% of patients. Okay, right. What is the diagnosis for this clinical picture? Many of, right, that is your ADPKD. That is autosomal dominant polycystic kidney disease, right? Then, okay, one last question, then we'll wind up the session. 49-year-old man with history of type 1 diabetes mellitus is admitted to the emergency room with an epileptic seizure, has a chronic renal failure and has been receiving dialysis for the past 3 months. Medication include ramipril, amlodipine, aspirin, calcium, vitamin D, periodic injections of recombinant erythropoietin, which were begun recently. On examination, blood pressure is 145 by 85, temperature 37.8, GCS 13. And these are the investigations given. Which of the following is the most likely cause for a seizure? Okay, so Hari says ischemic stroke. Why, Hari? Why are you thinking of ischemic stroke? CT, there is no focal lesion at all. Right. So, but Hari, you have answered E and your explanation is something else. CT rules out only hemorrhage. Very good. That's a correct point. It's a valid point. Right. Your answer is E, but your explanation is something else. Huh? Okay. Now let us just think of the ischemic stroke. When there is an ischemic stroke, you will have a neurological deficit or will you have a seizure? Ischemic stroke, they'll have a neurological deficit, right? Focal neurological deficit will be there. But does this patient have any focal neurological deficit? There is no focal neurological deficit given in this patient. So it is less likely to be ischemic stroke, right? Your explanation is correct, but your explanation is correct for something else. Anyone can answer? Very good, Jacob. That is erythropoietin-induced epilepsy. So that is one of the rare complication of erythropoietin, right? And some of you have answered C, uremic encephalopathy. Uremic encephalopathy, how will you rule out uremic encephalopathy? Yes, definitely creatinine is elevated. Okay, but that might be because of the receiving dialysis on the alternate day. And the other thing is, yes, receiving dialysis for past 3 months. But the problem is the creatinine is still on the higher side. But in case of any encephalopathy, when you're using the word encephalopathy, what will be the early manifestations? The early manifestation in encephalopathy will be altered sensorium, right? Altered sensorium. That will be the early manifestation, which is not given in this patient, so unlikely of your uremic encephalopathy. The answer here is erythropoietin-induced epilepsy. It's one of the rare complications associated with erythropoietin. Now you can ask me, how erythropoietin will cause epilepsy? That is what Hari was giving the explanation. Erythropoietin, when you are giving, what it will do to the hemoglobin level increases. That will cause polycythemia. And because of the polycythemia, because of increased viscosity, there can be decreased cerebral perfusion. Yes, even GCS also will be less than 13 in case of uremic encephalopathy. GCS will be something like 8 or 9 or even 7 or 8 in case of uremic encephalopathy. It will not be 13. Okay, so the answer is erythropoietin-induced epilepsy, right? And okay, now this patient is there in front of you. What is the drug of choice now? Having epileptic attack in front of you. What is the drug of choice that you'll give in these patients? So drug of choice is when the individual is having an epileptic attack in front of you in the emergency department, you have to give lorazepam. Not midazolam. Midazolam, it will cause respiratory central depression also. So we give lorazepam. Lorazepam would be the ideal drug, right? Okay, so the answer is D. That is erythropoietin-induced epilepsy. Fourth option. Next. Okay, one last question and then we'll wind up. Did anyone see the answer? Okay. So 72-year-old man with history of hypertension presents to emergency department. He awoke in the early hours of morning with severe shortness of breath, as if he is going to gasp his last breath. You understand that his GP has commenced him Ramipril 5 days, a short time ago, for hypertension. On examination, he had blood pressure of 175/85, pulse 100, left ventricular failure on 2D echo. You manage him with nitrate infusion, furosemide, and he improves. Investigations are given. What is the most likely cause of his presentation with pulmonary edema? Very good. So he has renal artery stenosis. But why did he develop now the shortness of breath? Ramipril. The patient was started on Ramipril. Okay. So yes, he might have had bilateral renal artery stenosis. Now added Ramipril, right? Precipitated the renal failure. Precipitated the renal failure, right? Or precipitated the fluid overload that caused left ventricular failure. Okay, right. And because of hypertension, there is hypertensive heart failure, left ventricular failure. What is the ideal treatment in this patient now? What would be the ideal patient treatment? After stabilization, what would be the ideal treatment in this patient? PTRA, percutaneous transluminal renal angioplasty. Vinita, patient is having left ventricular failure. Will you give calcium channel blocker? Calcium channel blocker should not be given in case of heart failure. That's a very, very important point. Okay. Right. So the answer is PTRA. Because there is bilateral and because of which the blood pressure is also elevated there. Okay. So the preferred treatment is percutaneous transfemoral renal angioplasty. Right. So couldn't understand why creatinine was high despite regular dialysis in the last question. Yeah, that was a very good question. See, the reason why the creatinine is high is the requirement of dialysis. He's there on dialysis since 3 months, and he might have been undergoing dialysis with lesser frequency. The requirement might be 3 to 4 times per day. He might have been undergoing 2 times dialysis per day. We don't know. It has not been mentioned. Even potassium also, if you see, it is on high normal side. It is high normal side, the potassium also. So that is the reason why the creatinine might be on the higher side, because of the frequency of the dialysis. Right? Did you understand that, Jacob? Otherwise, no other options given to you will explain why there is high creatinine. Only we need to think that the frequency of the dialysis. Please upload notes of today nephrology day 2. Yes, Sharath, I will do that. Okay. Right. Let me do it now only because once the class is over. Right. So I'm uploading the notes on my Telegram channel. This includes both. This PDF, what I'm sending now, this includes both. That is yesterday's and as well as today's. Both of them in the same PDF. Right. So with this, I'll wind up the today's session. And you'll also have a quiz today. Same yesterday, like you had 25 questions. So today also you'll have 25 questions on the nephrology. Right. So I hope you have understood, enjoyed, and thoroughly understood the concepts also. So how was the session? Right. So with this, we'll wind up, and please thoroughly revise the topic and try to give the quiz, which we'll be having on my Telegram channel at 10 o'clock. Right. So thank you very much, and it was very, very good interacting with you. Don't we need to add up any other drugs in erythropoietin-induced epilepsy? We need to stop erythropoietin first of all, Manisha. It's a good question. So we need to stop erythropoietin first. If it is erythropoietin-induced epilepsy, stop erythropoietin. Then if it is recurrence in spite of stopping erythropoietin, then we add anti-epileptic drugs. Because anti-epileptic drugs, you might have discussed that in your epilepsy topic also. One episode of seizure, it's not an indication for starting anti-epileptic drug. Right? You need, if there is any underlying cause for that epilepsy, for example, hypoglycemia causing epilepsy, will you add any anti-epileptic drug? No. We give glucose to the patient. That's all. Okay. Is that clear, Manisha? Right. So thank you very much. And I wish you all the best.